documents. Okay, so everything that we're going to be going over is in your course documents. The whole purpose of being here today, though, is to explain these documents to you and what's required of you and what kind of clinical sites you need to be looking for and how many hours you need to be arranging for and those kinds of things, okay? Before we get started, I am Angela Thompson. I'm the director of the F&P program here. This is my first year being the director, but my fourth, I think, year teaching here. For those of you, I think I may have had some of you, if I had some of you in, yay, good to see you again, in different classes and especially patho. But I am a nurse practitioner. I am a very busy nurse practitioner, and I also love what I do here with students and in working with the program. I'm excited to be the director. We have some great changes and stuff that are going to be coming about, and you being new students are going to probably be involved in some of those changes that we're going to be doing, but we'll let you know all about those as time goes on. But there are some progressive things that we're going to be doing as a program, so it's an exciting time, and I'm excited for all of you. One good thing is I just got a call from a potential employer who wants to know if we have any NPs that are available for employment. So it's always nice when you're getting calls to employ your students. So keep up the good work, and hopefully one of these days that'll be you, and I'll be able to say, yes, by the way, I do have some students that would love to come work for you. So this is Carol Carroll. If you have not met Carol, she is literally, she's like the undercover person in charge. She's the right-hand person here who really makes a lot of things happen. And you will be emailing her and contacting her and sending her all kinds of important documents. She's the one who keeps track of all of your clinical sites, and sometimes will help us with preceptors, and she's just a jack of all trades. So she's a wonderful asset that we have here, and I know you guys, if you haven't dealt with her already, will be dealing with her with your clinical contracts and such. There is one page that is not in your folder. It's the other thing that I was running around doing. Dr. Bischoff is the director of the administration and education portion of the MSN program, and she had helped me update the order form for your PIN, for your identification that you have to have when you go into the clinical setting. So she had ran off the new order forms for you. This is the only document that is not accurate in your course syllabus, and we will update that. She has the actual document now, so we'll update it before the courses open on Monday. So this is the actual form. If you want to fill it out now, you can do that. Have any of you been to the bookstore? So you might want to order your name tag if you haven't done that already and get that moving. So I'll just pass the pile around and take one and pass it along. Just going to grab a quick drink here. Anybody Notre Dame fans? My daughter goes to Alabama, so roll Tide. Yes, we did. Yes, we did. All right, so if you open your booklet, the first thing there's a lot of heavy papers on the one side, and then there's not so much on the other. We're going to go over this big, thick side first. This is the first document. This is your clinical information sheet. For every clinical site, and please chime in, Carol, anytime, if there's something I forget.
Chime in right now.
Okay.
I think I have revised one, and it's the one that I emailed to everybody. And it includes the preceptor or the preceptor's office manager's email address, because if we already have a contract with your site, I can email them the preceptor packet. There's no sense mailing it. It gets there much faster and costs us less postage. So if you use this
This is a form that for every clinical site, or the updated form that Carol was talking about, for every clinical site that you attend, we need to have one of these on file. We need to make sure that we actually have a clinical contract with that person or with that facility. Sometimes it's a hospital, sometimes it's a physician office, sometimes it's a clinic. We just need to make sure that we have that information on here, and also that Carol will make sure of getting the preceptor packets in the mail, because what the preceptor packet has in it is information on what your course objectives are, so that they can kind of help to guide you with achieving those clinical objectives for whatever particular course you're going to be in. And the other thing is, you know, they can get CME credits for being a preceptor for you, so there's information about that. And of course, there's a contract that the office manager has to take care of and all those kinds of things. So this piece of paper is very important. For your clinical instructors, speaking of which, this is Karen Fahey. She is predominantly teaching most of the 531 clinicals. So this will be probably 3/4 of you will have her, if not 99% of you will have her for your 531 clinical, and maybe 531 didactic as well. So feel free to chime in anytime. Okay, one of the most important things to your clinical teacher, not necessarily for 531, but for the other 4 clinical courses, 565, 566, 567, and 568, is the section that has your clinical dates. In the other 4 courses, other than the one that you're going into right now, you will be visited by a clinical instructor. It may not be your particular clinical instructor, but someone that is employed as a clinical instructor by Wheeling Jesuit will be making a visit to your clinic to see you, to assess you, to make sure that you are meeting the objectives of the clinical. This is your contract with us that says, yes, I'm going to be there on that particular day on these particular hours, so that when we show up, you're there. You don't want to not be there on a day when you're supposed to be there and not notify someone and we show up to do a site visit. That is not good. So please don't do that. Obviously, people get ill, preceptors get ill, preceptors have family that get ill, things change. We realize that. But please make sure that you email or send your, call your clinical instructor, especially if they have been courteous enough to arrange the site visit ahead of time with you. That is what we try to do. We try to make arrangements to visit a number of you at a time. You know, we will take a day off from our clinical practice to venture all around West Virginia, Pennsylvania, Kentucky, Ohio. So we try to visit as many of you in a 24-hour time span as possible. So to drive 2 or 3 hours out of the way only to find out that you were ill that day is not good for us. So just be courteous, but that part is extremely important to your clinical faculty, to make sure that they know where you are when you say you're going to be there. The other thing, we had a situation that came up that I just want to mention. You know, I'm new to this position, so all these things are going to be new, and we're going to be dealing with them as time goes on. But one situation that we ran into this semester was that a student had completed her hours. She had done her X amount of hours that was required, but she had told the facility that she was going to be there another day. And they, had a particular procedure that they were going to be doing, and they thought she was going to be there. They had pretty much counted on her as help, which they really shouldn't do, but they did. And then she got home and was doing all of her logs and stuff and realized, oh, I'm done. I have my hours. So she called, but she called very early, and they didn't get the message that she wasn't coming, that she had completed her hours or whatever, and that didn't go over well with the preceptor. So I end up getting phone calls and, your student isn't reliable. We had this big procedure. We were planning on her being here. Which is, like I said, it's not exactly what they should be doing either. They shouldn't be counting on you as being their help. However, if you have an opportunity to get an extra clinical day and you've already arranged that day, they think you're coming for that day, it's certainly not going to hurt you to get a few more clinical hours, okay, if you've already made arrangements for that day. try to make sure those are your commitments. All of you are already professionals. You're already nurses. You're already been through a lot of school already. So you know what it means to be professional and what professional behavior entails. So make sure that you, if you're supposed to be where you're supposed to be there. Okay? Any questions so far about that piece of paper? The sooner that you get them done, the better. Clinical sites, typically for 531, they're really not a major issue. As you progress through the courses, though, they can be. Pediatrics and women's health are our two most difficult places in getting preceptors. And the reason for that is because there's not a huge population of them around anyway, and we are competing with a lot of other schools, as well as residency and med schools and things like that, PA programs. So the earlier that you can be in touch with those people and making those arrangements, the better. And the closer relationship that you keep with them, the better, letting them know that yes, you're coming, because a lot of times I hear horror stories about students that have to withdraw from a course because their preceptor pulled the plug at the end. They were ready to go, paperwork in tow, and lo and behold, they honor another commitment, or they just basically tell a student. And sometimes, I've been a preceptor, so sometimes it's difficult. Sometimes it gets wearing. Not anything against students at all, but sometimes just your own clinical practice is a lot of stress. And to always have, to be that teacher can be stressful as well. So sometimes they just need a break. Okay, any questions so far? Okay, your next piece of paper is your,
I'm sorry,
yes, go ahead.
can you take the class without the clinical?
No,
You get yourself in that position where you have no preceptor?
no. They have to go together. That's a very important question because we've had to deal with that too. We've had to deal with situations, because these classes are, your clinical courses are separate. So, you know, a lot of times students will pass a didactic and fail a clinical, or pass the clinical and fail the didactic. They're separate classes, but initially for your first time around, you have to take them together. Then when you have a failure, you're not going to have any of that. Then we'll deal with those issues as they come along. So.
What would occur if it happened in the middle of your semester, if your preceptor cut bait?
I've never had that happen. Have you had a situation where that's happened, Carol? Where a preceptor has decided in the middle of a semester not to have a student back?
We've had a situation where a student got ill in the middle of a semester and had to
Yeah.
withdraw. And in that case,
Sometimes, depending on where it is in the semester and how far along you are, how much work you have completed, we will do an incomplete with the student. Students have to have surgeries, and spouses pass away, children have awful illnesses. Yeah, there's all kinds of things that happen. And I hope that you find that our faculty is kind of very accepting of those kinds of situations. We realize that we've all been through a number of life issues ourselves, and you know, we know that the one thing that we don't want to do is catch you in a lie about something. Other than that, we're pretty forgiving for those kinds of things, and we will try to work with you to get that course completed, whether you take an incomplete and then finish up, or you know, whatever you need to do. I have had some students that have had to do that, where they have not been able to get enough OB hours in, where they've had to take an incomplete and do clinical time over the Christmas break, and then they finish by the time the new semester starts. But hopefully that won't happen. But we've kind of had some of those kinds of issues, so we'll cross those bridges when we get there. Okay. Did you have a question?
Yes. Can your clinical time consist of office and hospital, or strictly just office?
No, it's a variety. They're out there doing all kinds of things. I was kind of shocked at what all they're doing, but we have students that, you know, will be doing clinical time. For instance, in women's health, they might see patients in the office on Mondays, Wednesdays, and Thursdays, and they go to surgery with them on Tuesdays. So they're in the hospital, they're rounding, they're doing all kinds of stuff.
I just had a group that was asking if we had to strictly stay within the office or if we could go to the hospital setting as well.
Right. No, hospital setting is fine. The big issue is I get a lot of, can we go to the ER? Can we go to, pediatric cardiologist? Can we go to a pediatric endocrinologist? Bits and pieces of those are fine, a few days here and there. The biggest thing that you need to remember when you're getting your clinical sites is that your focus is on primary care. Primary care across the lifespan. Okay? So you need to be able to deal with those patients that are coming in for well visits and basic ill visits on a daily basis. Not your patients that are, have a million illnesses and are seeing 10 specialists. And if you're their primary care, that's fine. But to actually be in those specialty areas and getting a whole lot of specialty work is not what your focus is, because it's not what your certification test questions are going to be. Okay? That's what our focus is primary care. Somebody else had a question. Yeah?
For the women's health,
Mhm.
can it just be gynecology?
No.
Because there are several physicians who said, oh yeah, you can do it with me, but they don't deliver.
Right, exactly. No, it cannot. It has to be a combination. Yes. You can do 3 or 4 if you have to. I mean, Carol doesn't. It's more work for Carol. But if that's what you have to do to get your hours in, that's what you have to do.
And is it broken down somewhere to tell you how many are
We're going to be working on that because we had an issue with that this semester. So coming up around, yes. We also are, now this isn't official, and I really don't know if I should breathe it out, but we are thinking, check the summer schedule, because we are thinking of adding or piloting or trying to do our women's health 566 compacted all summer, but compacted into the summer, so that there's less competition with our students getting clinical sites. We might try it once just to see how it goes. So I can't swear to it. I'm not writing it in blood. I'm being videotaped, so there's evidence that I didn't swear to it. So, but just keep your eye on the summer schedule, because that might be a possibility for some of you. Any other questions? We'll talk more on clinical things as time goes through here. Your next piece of information is, this is what you're graded on for your clinical log. We're going to talk about the clinical log next. But this is when you turn in your clinical log, this is the information that you should be putting on it, that your clinical instructor is going to be looking at to make sure that you're doing what you're supposed to be doing when you're in the clinical. And the next page is what your clinical log looks like. You need to put your name on it, the date, where you're at, who your preceptor is, preceptor information. Preceptors can be physicians, meaning MDs or DOs, and they can be nurse practitioners. They cannot be PAs. Okay? Cannot be PAs, even though there's wonderful PAs, they can't be a PA. Okay? Nurse practitioners have more responsibility in primary care than PAs do, so you can't be precepted by someone with less responsibility than what you have. Okay? I'll say that in the nicest way I can. So a DO, an MD, or an NP. Okay? So list your preceptor, the hours that you were there, and you're going to keep the next column is cumulative hours. So you keep a cumulative, keep adding onto it so that you just have a running total of your hours. And then you have to, every day that you were there, have your preceptor sign that, yes, indeed, they were there. Okay? We had some situations where students like to double dip, or maybe use their office time. Maybe they work for a physician and they use the little work hours here or there, and that's why this has to be signed by your preceptor, that you have on file with Carol that you were there for those days, so that we have proof to your certification body that you put in your hours. Oh, no. So that, we keep them. We have them. But that the preceptors match with who you have. That's what I'm saying. Yes. It's hot in here.
Calling and saying, I don't know if it's for their board or if it's for their license, but they've been asked to provide an entire list of every preceptor and site they used while they were in school here. And I don't have that information, so you might want to keep track of that for whatever it is you're going to be needing that for.
It's always good that anything that you're sending to us, like important documents, that you always have a copy of that too. Like your information from your preceptors and your, who your, where your clinical site's going to be. I would always keep a copy of your clinical log that has your hours on there and has all the signatures on there. There's also another document where you're documenting all of the procedures that you do. You definitely need it. You have to turn that in every semester, but you definitely need to keep a copy of that as well, because sometimes they will ask for things that we don't necessarily have, or you turn them in as part of your work and we give them back to you, or they're in some course somewhere through Blackboard. But that's sometimes typically maybe something that we don't actually have a paper copy of, that we would have to go in and actually find it in the course, print it out, and get it back to you. So I would keep everything. Okay. The next page is an example, a first page of what your clinical log will look like. You put your name, the date, time, and location. Patient will just be initials, the age of the patient, the sex of the patient, what the diagnosis was, and also what assessments you did, what treatment, what kind of care, what tests were ordered, that kind of stuff. This semester's focus is on advanced assessment and introducing you to what is called differential diagnosis. Have you ever heard of differential diagnosis? Okay, that's good, because sometimes at this level it's very foreign. And I can tell you just from grading some patho case studies and stuff, that the way that you're thinking as you progress through these clinical courses will progressively change. In grading some of your case studies in patho, I could tell that you still have your nurse's hat on, which you will always have your nurse's hat on, which is what makes NPs great. But the way that you're thinking and the process that you're thinking and how you're working through that is going to be changing. And this probably is the most important of the 4 courses. It may seem like it has less clinical hours. Oh, this is easy. I've done physical assessment before. But it's those history-taking skills. What questions do I ask? If I get a piece of information, what question does that spontaneously do I ask based on that information? Because putting all of that together, putting all those pieces together, is what leads you to that differential diagnosis and ultimately to the real diagnosis that your person has and how do you treat them. Most of the time, you can begin to formulate your differential diagnosis by the questions that you're asking and the information that your patient, paying attention to what they're telling you, will give you a lot of information as to what you want to order, what doesn't need to be ordered, maybe what they're concerned about, and maybe thinking that they want to have ordered, you don't necessarily agree with. So, by doing your assessment and explaining what your findings are, then they're not worried about that anymore because you've explained that away for them. But this is what you really need to worry about. So we need to get this test instead, or whatever. I was told by probably one of my biggest mentors when I first started in women's health. He did a brochure to advertise it. He had an NP and we were working together. And one of the quotes that he put in the brochure was that the most important thing that we can do for our patients is listen to what they tell us. So this class teaches you those listening skills and what questions to ask. And then with your physical assessment too, don't be discouraged at the end when you're doing this enormous physical assessment you have to get graded on. And sometimes you don't understand all of the components of it. But as time goes on, for instance, with women's health, because most students are very uncomfortable doing the women's health clinical, having to do a pap smear and a pelvic exam, very uncomfortable for the patient to have to go through that anyway, much less with an inexperienced provider trying to do that. But as time goes on, your assessment skills build and you get more comfortable with what you're feeling. And is that a true breast lump, or, your hands are your tools, and they get better and better and better. These assessment skills build and build and build as time goes on. Once you finish this class, this is just the beginning. It gets better and you learn more and more and more as time goes on. even when you graduate, you are only at the beginning of what your career is really going to be and what you're really going to be as that NP, and your skills will get better once you start working and seeing patients on your own, and it just gets better, okay? But this is a very important class. This is the foundation of all of the rest of them, okay? Okay, next page is your patient assessment rubric. And we're going to skip these next two pages, just put them aside. And these are just general kind of worksheets that you can use. You can use them if you want to. You don't have to turn them in. These are just things that you might want to fold up. You know how when you used to get report and you'd write everything down on your patients and you'd fold it up in your stick it in your pocket. That's what that's kind of what these are, so that you can kind of keep track of what you're doing for these patients and take it home to be able to really write your physical assessment stuff on. And then this is the first page. The second page has the review of systems, questions to ask for review of systems. So this is something that you can use if you want. If you want to create your own, you can. And in the era of medical records, electronic medical records, this is difficult for students because sometimes you don't get access to those electronic medical records, and you can't just say, can I copy this or can I print this, because that's taking the patient, it's like taking a patient's chart home. You can't take a patient's chart home, so you can't take their electronic medical records home either. So a lot of times you're scrambling to get the information for the brief amount of time that you have access to that computer. So whatever system you develop or want to use is fine. This is just something that the faculty put together that you might want to use. Okay. We'll get back to your assessment thing. Next is your SOAP note. These are your SOAP note expectations. They're pretty straightforward. And this is your grading rubric. Next two pages. Everybody knows what SOAP notes are, right? You know what nursing SOAP notes are. And probably haven't documented much with SOAP notes because you've probably done a lot of narrative notes, right? What you do as an NP is all written as a SOAP note, okay? So when they come in, your S is going to be what they're saying to you. Literally, what are they saying? What are they telling you? Your O is going to be your objective information, your assessment. Okay? And then on the A, which is assessment, don't get that confused. That's really what your diagnosis is. Okay? What do you think this is that they're complaining of? And then your P is your plan. What are you going to do? So subjective, say a pediatric patient might be your subjective, and your subjective should always be in quotes because this is what the patient or the patient's mother or whatever is telling you. So say you go to a pediatric clinical and you go in to see a patient, maybe you have a 3-year-old that's been pulling and tugging at their ear and has a runny nose and running a fever, and mom tells you that. He's been up, can't get him to sleep, he's not eating, he's pulling at his ear, he's got a temperature of 102, he's got this runny nose for 2 or 3 days. That's what your S is. Then your O is going to be your assessment. What did you see in those ears? What did you see in the nose? What did the the pharynx look like? What did the membrane look like? What in general does your child look like sitting there in front of you? What's your assessment is the O. Then your A, probably going to be an otitis or a sinusitis, or so what are you drawing from that information? What diagnosis are you getting? That's your A. And then your plan is what are you going to do? If you think it's a sinusitis, are you going to do an x-ray? Are they of an age to have an x-ray? Are you just going to put them on some amoxicillin? What's your dose of amoxicillin? That's what your P is, okay? So that's what your SOAP note consists of. That's what you're going to be writing every single day. A lot of times, what you don't realize as you go through this course is as you document, so you get paid. So ultimately, what you're learning right now is extremely important because on the opposite end, when you're working, insurance companies will pull this note and see, they billed for a level 3. Is this truly a level 3? Do they have all the components of the note that a level 3 gets? And they will say yes or no whether they pay you or not. And they might have already paid you and you have to pay them back. So documentation is extremely important. And we're going to be teaching that also as we go along. You'll see in your examples how your notes of doing a head-to-toe assessment, what's their chief complaint, what's their history of present illness, all of those things become really thorough but very important. Okay? Any questions? Okay. Your next form, I just printed off the abdominal assessment. As you go through your course content for this course, periodically you will have to turn in what's called regional assessments, where you're going to be focusing on a particular region of the body, and you'll have to turn those in. This is just the abdominal one. There's about 6 or 7 different ones. A head and neck, I don't know what all else. There's a chest, there's a heart, you know, respiratory assessment. They're all in your course. And you will have specific dates that you will have to turn in a couple of these on the patients that you're doing until you get all your systems covered. Okay, this is just what a regional assessment looks like. This is just the abdominal one. And this is your assessment. This is how you write it up. This is basically your SOAP note, okay, S-O-A-N-P. And then this gives you an example. If you go back to the page that we took out where it says Patient Assessment Rubric, this is an example of what your real patient assessments will look like. And it's a several-page document, if you will notice. This is when you're going to actually do like what a new patient would come in for. This is the type of write-up that you would do on a new patient. So you have your cover sheet. Okay, make sure to remember, what do we use for every document that you turn in? APA format. So you have your cover sheet, and then and this is all in your Swartz textbook. It all is right there. Source and reliability is who's the source of the information. Did you get it from the wife? Did you get it from that actual patient? Did you get it from the mother? Did you get it from a caregiver? You know, who was your source and how reliable were they? If all you have is the 89-year-old patient with a history of Alzheimer's, how reliable is the data that you're getting? Well, we really don't know. So who gave you the information and how reliable were they? Chief complaint. Okay, what are they here for? What are they complaining of? Okay, are they here for a well visit? Are they here because they have chest pain? Okay, what is the chief complaint? Identify the chief complaint. History of present illness. Okay. This is called HPI. This is where you get a lot of bullets for Medicare billing. You have to, when you're doing HPI, you have to think about asking all the questions. Where, when, what makes it better, what makes it worse, what have they tried, you know, where does it hurt, how bad does it hurt on a scale of 1 to 10. All of those kinds of nursing kinds of questions that we're used to asking comes into the HPI. The more you ask, the more bullets you have, the better your documentation is, the less issue you're going to ever have with billing. Okay? Electronic medical records actually help with this too. So, past medical history. You know, what is their past illnesses, past injuries, past surgeries, anything that, you know, needs to be documented. Do they have a history of asthma? Have they had their gallbladder out? If they did have their gallbladder out, was it a laparoscopic gallbladder? What year did they have it out? If they had a hysterectomy, was it a total abdominal hysterectomy? Was it a vaginal hysterectomy? Do they still have their ovaries? They have one ovary. Do they know which one it was? All those kinds of things. Tonsils and adenoids, when did they have that done? Surgeries, you know how to list all the surgeries. Any allergies? Are their immunizations up to date? Immunizations are big these days. Because you have all these extra immunizations that patients are getting, flu shots and Gardasil, and you know, you'll learn all about immunizations in peds, but there are adult immunizations as well. So, you know, look at the immunizations, are they up to date? Any history of substance abuse? You know, sometimes those are difficult questions to ask, but sometimes you just have to ask them. Any history of substance abuse? Do they use alcohol? Are they a smoker? You know, any illegal drugs? sometimes this is really difficult in my profession because I do women's health and I have a lot of young patients. So I have a lot of patients that are underage that will say they drink. So, that's sometimes difficult. So you have to ask those questions. Sleep patterns and current medications. If you can at all list their dosages, that's good, but just having a list of their current medications that they're on is good. Any kind of occupational and environmental history. Living in the Ohio Valley, that's very important. What kind of environmental exposure have they had? Did they work in a plant all their life? Have they been exposed to, asbestos as far as construction goes? We live in a coal mining plant area, so environmental things is a very important question. So make sure you ask those. Family history. Any kind of family history. Are their parents living? Siblings? Do they have high blood pressure? Almost everybody, this is funny because since we've been doing electronic medical records, I wish that they would just check that everybody has a family history of diabetes, heart disease, and hypertension, and then let me go in and take the X off of the ones that don't. That would save me a lot of time. But it doesn't work that way. But you'll find that tons of people have a history of diabetes and weight issues, heart disease. But get a good feel for their family history. Psychosocial, spiritual history as well. Are they married? Do they have children? What do they like to do? What religion are they? Sexual and reproductive health just simply means, are they sexually active? And are they behaving correctly if they are sexually active? Meaning, are they getting STD screened? Are they using condoms? That kind of stuff. If there's any teaching and delivery information, are they a Gravida X, para, whatever, C-sections, preterm deliveries, all that goes in that section. And then the next portion is the review, is that right? The review of systems. And that goes back to that other page that we gave you, which is just a ton of questions that you just kind of have to go through. And you don't have to ask them every single one. Review of systems is like an overview. Do you have any allergies? Do you have any respiratory problems? Do you have any shortness of breath ever? Do you have any leg pain, chest pain? Hit and miss a good many of them. That's a review of systems. You don't have to sit and ask a million questions. Take 30 minutes to answer all the review of system questions. But, kind of look at the big ones. Have they ever had a DVT? Things like that. And then you do your physical assessment. It's also documented in here. And you also have to include a genogram. There are some programs that you can use that are free, I think, that you can download. We're not major sticklers on having a, some people will just draw it out and attach it. That's okay. These obviously look much prettier. They have colors and arrows and all that kind of stuff. But not necessarily this last certification exam, but the one before that had questions on a genogram where you were presented with a genogram and asked a question based on the information in the genogram. You had to answer the question. So you need to know what the solid lines mean, what the dotted lines mean, all that kind of stuff. So make sure that you're doing your genograms correctly. Any education that you need to put on there, any discussion, and then make sure that you include your references. And I will tell you that the references on this page are not correct. That is not correct APA format. Bad girl. Whoever did this one, I don't know who did this one. But chances are it was done before the APA changed. So anyway, that should be double-spaced, right? All references are double-spaced. Okay. At least in the current edition. We'll probably get a new APA book this time and it'll mess us all up. Okay, then the next page is how this big document is graded. This major document that you've put all together looks very nice. This is what your teachers are using to give you the points for it. Okay? So this is where your points come from when you get those grades. And this is the very last section. At the end of the semester, you will be making arrangements to come to campus. We usually do it in a week or two, Karen? You usually schedule it? Yeah, last 3 weeks. Okay. Last 3 weeks of April, you'll be signing up at a particular time with a partner to come to the lab and actually do this assessment. This is what you're graded on. So look it up and learn it, and you'll be fine. It's just basically a head-to-toe assessment that we get to check you off on. And Karen's really not mean. Usually we let you keep a little note card so that, I mean, a lot of it you know already, but there's maybe some things that you might not remember. So you can generally write yourself some notes on a little note card. What else did I need to tell you? Your SOAP notes and your assessments for 531 are very general. I think you have to do them on different age groups. And that's why we wanted you to make sure that your clinical site was in a family practice that dealt with children, you know, reproductive females or women of reproductive age, menopausal women, and the elderly, so that because your requirements, your written requirements are for those particular types of patients. When you get into 565, 566, 567, and 568, some of your focus on your notes that you're turning in will be divided into like regular SOAP notes, or they might be pharmacology notes. And the reason for that is because those you have to turn in X amount of pharmacology notes per year, because they count toward your pharmacology hours, and you have to have X amount of pharmacology hours to graduate and be able to sit for the exam and to have your pharmacology credit to have prescriptive authority, at least in West Virginia. Okay? Any questions about that? I know that was a lot to kind of throw at you, and as you take time and sit and go through the documents, I think it'll make more sense to you. Yeah?
I live 5 hours away, and so I wasn't even really planning on coming, but I took another trip. Will I have to come again in April? I will.
Yeah, unfortunately. And we're getting many people, and I'm glad you bring that up, because even doing your clinical site visits and stuff, sometimes that can be very difficult. We try to get out as far as we can as faculty people, but sometimes it's too far out, and we have to kind of meet in a middle ground. We do have a faculty member, a full-time faculty person that is in the Charleston area, so she typically covers southern West Virginia and some of our southern areas. But sometimes if you're living pretty far out, we might require you to actually come and spend a day with one of us, clinical-wise, to get your evaluations and stuff in. That's something that, as a faculty, we're really having difficulty with, because we want to expand the program as much as possible. However, the board that accredits us mandates that we do site visits. So that kind of ties our hands with how far out we can get to patients, or to students. But we have students that are relocating from North Carolina. They come here for a couple years, and then they're off back to where they were. We have someone who just moved to the upper East Coast, Connecticut, and those places. We've had a student from Texas that has had to fly in and do their clinical evaluations and stuff with us here, so we do what we can. And those are some of the things that, as a faculty, we're all working on, what we need to do, what we need to change, how we can expand, that kind of stuff. So you had a question as well?
Do we need to have more than one clinical site for this semester?
That's a good question. Did you put in there the ophthalmology thing? Okay, I can't swear to that, actually, because the last time I taught the clinical course of 531, we had students that they did their regular practice, but they also did like a day in an ophthalmology office to get eye exams in. And if that's in there, that's in there. I don't know that I've seen it the last year or two. Okay, so the answer would be no, but. But that certainly doesn't mean that, if you wanted to do a day in an ophthalmology office where you actually get to Because doing an eye exam is, that's not something that you get to do every day. When you are, but that's something that a lot of doctors' offices, should be at least looking briefly in the eye and identifying the red reflex and the, optic nerve and that kind of stuff when you're doing an eye exam just with the ophthalmoscope in the office. And if you've never used an ophthalmoscope, then you don't really know what you're looking at. And sometimes in your undergrad assessments, you might not have had much of that. So spending a day in an ophthalmology office or even in an ear, like ENT office and stuff is sometimes not a bad idea. But I guarantee you after you do your pediatric rotation, you'll be skilled at looking at ears. Ears, noses, and throats. Yeah.
If you have a regular primary care physician who does do birth to children, can that be your pediatric person?
Well, that's a good question. In pediatrics, in 565, we try our very best. We really want you to exhaust all of your possibilities of getting into a pediatric office first. If you can't get into a pediatric office, then we do allow you to do family practice as long as that family practice sees a good bit of pediatrics. What we don't want to happen is for you to spend 168 hours in a pediatric clinical and 90 of those hours you look at your log and you've seen adults. Because really that's not what you need to be doing when you're in that pediatric clinical. And in those cases, sometimes we, say, okay, do as much pediatric in your family practice as possible, but can I go to a pediatric cardiologist? Can I go to I'd rather you do some type of pediatrics, even if it's a specialty, than be sending me soap notes on adults.
Because I know Wheeling has when you are low on the food chain, residents and
Yes.
that kind of stuff. But what I do know is that sometimes they'll let you, if they have one day open, they'll let you go in with a pediatrician, but you might not get 168 hours. But we have several physicians
Yeah.
that would have told me, oh yeah, come over and I'll let you do between the two, I think that I could get a decent amount of pediatric time.
Yeah.
But it would be hit or miss and spread thin with actual full-fledged.
Pediatrics. And sometimes you get good experience in it. I would rather you just spend time in an urgent care than necessarily in an ER, because urgent cares have a tendency to get more of the kids that are sick, and the parents don't want to spend hours in the ER. Let's just go to the urgent care, and you'll get a lot of stuff there. And a lot of times with kids too, you need to do the sports physical. So a quick run to the urgent care. I need my sports physical. Can you fill this paper out for me and do the sports physical and that kind of stuff? That's all part of primary care, so that's all fine. It's just that it's sometimes very difficult. I will also, let me throw this out there, students that live near the border, I highly recommend to go ahead and get whatever surrounding licenses that you possibly can. If you live in this area, if you can get licensed in Pennsylvania and Ohio, please do that so that you can be looking for clinical sites in those areas, because yours may be locked down and by the time that you need them. So if you live like in Parkersburg, I had students that did clinical in Marietta. They got their license in Ohio and got their OB hours in Marietta. They did some in Charleston and some in Marietta because they lived in Parkersburg. They were going back and forth. So if you live anywhere around those bordering states. I've had one student that took her 2 weeks vacation. She found a site that would take her for, 2 weeks. She went 2 weeks and lived in a hotel for 2 weeks, left her kids, left her husband, lived in a hotel for 2 weeks, and did probably 90% of her hours all in that time frame just to get it done, because she had someone that she could do it with. And he was like a rural care kind of doctor, so they were like out in the country doing house calls and everything else. So yes.
I just wanted to clarify for the pediatric rotation,
Not as your primary site. You really need to look at family, because urgent care is not primary care. Okay? You need to look at family practices that see a large number of kids for peds, or pediatric offices first. And if you say you can get in with them, but they're only available X days a week that you can be there, and you need to add to that by going to an urgent care for you know, however many hours, not the majority of your hours, then that's an okay thing. But the majority of your clinical hours should come from a pediatrician office or a family practice that sees a lot of kids. Okay. And that's why we typically have peds in the fall, because that's typically when you see most of the ear infections and croup and all that kind of stuff. Usually from the November, March, April time is when they're more busy with those kinds of illnesses. So,
Do you utilize the health department?
absolutely, especially women's health. Women's health is a good place for you to go get pelvic and pap smears and breast exams and well child clinics. Yes, well child clinics, very good through the health department. Do you think of any other places? They don't do, I don't think they do like hands-on stuff. They might do house calls and stuff. And, Yep. Any other questions? Okay, the very last document on this side is this is just what all of your skills are listed. And if there's something that's not listed on here that you do, by all means add it. But it has all of your clinical courses, and I would just encourage you to keep this kind of handy and check it off. And all you do is little hash marks, 1, 2, 3, 4, and slash through the 5th one. Keep track of how many of these that you're doing so that you have a record of what skills that you got exposed to as a student that you got experience with, okay? And it doesn't have to be, say 531. Just 531, if you got to do something different in 531 and it's somewhere else, just mark it in the 531 column. It doesn't mean that, you may get to do a number of things, but just mark it wherever you get to do it, that's fine. Okay? And keep a copy of this. You'll have to turn this in every semester, so keep your running copy so that it's cumulative over the time that you're here. You can keep checking it off. Okay? Any questions?
How many hours do you need for the 531 clinical?
531 is 56 clinical hours, not very many. Okay, it's only 56 for 531. 565, 566, 67 is all 168. So it changes significantly as you go on. And I think 568, how many is that, Carol? Do you remember? 20, something like that. It's about 120, 130 for 568. And the way that the courses run, 565 is pediatrics, 566 is reproductive health, women's health, and in that semester you will do women's health as well as men's health, so you have to do a small amount of time, usually with a urologist, so that you can do some male exams as well. And 567 is adult, and 568 is geriatrics. So that's where one of the things that's going to be changing for you is we're not going to require you to do them in sequence. So that's something that's a little different than we've ever done before. You don't have to have, used to be 565 was a prerequisite to 566, and both of them were a prerequisite to 567, and you really don't have to do that anymore. And basically because the clinical courses all run the same. Your requirements are the same, SOAP notes are the same. All your requirements are basically the same. Most of your clinical hours are the same with the exception of 568. And the content really doesn't build. The content is focused on one particular age group. So for that reason, we decided to allow you to take them out of sequence. So, yes?
I do have a question, and I'm referring to this handout that I got today for the orientation. And I'm looking on page 16 where it says MSN rotation, family nurse practitioner. And I'm looking where it says semester spring year number 1.
Mm-hmm.
And then to the right, it has 2 or more classes, and of course it has MSN, the Advanced Health Assessment, 4 credits. But below that, it has also Primary Care of the Family, 6 credits.
Yes. Now, that's because 531C is 1 credit, and 531D is 3 credits for a total of 4. Now, 565, both the clinical and the didactic are 3 credits each. Okay?
Because I registered for the Advanced Health Assessment
Mm-hmm.
only.
Right.
Oh,
That's, no, that's fine.
okay,
That's perfectly fine.
okay.
No, and we prefer that you do that. We get into issues sometimes. Students want to finish, and believe me, I completely understand your rush to be done. But sometimes it's very difficult for you to take 2 clinical courses. Like some people will try to take 566 and 560, what is it? 8 at the same time. And that is extremely difficult because you have 2 clinical courses, you have all those clinical hours to try to get in. Most of you work, most of you have children. By the time you do all of that, it almost sets you up for failure. However, if you're one of those walking around, textbooks of knowledge and, you're all organized and your family's all great and you feel like you can do that, there are exceptions to the rule that you're adult thinkers. You've been making your own decisions all this time, so a lot of times we'll let you make that decision, but we really encourage you to think about that, and think it through before you decide to do that. Yeah. Yes?
Okay, my question pertains to the clinical log or patient assessment result.
Okay.
Every patient we see with our preceptor, we have to do one of these. See 15 patients in it, or 25 patients in it.
You have to keep track of that patient that you have to keep track of it on your log. On your log, you have to keep track of every patient you see. And you have to put in there their age, what you're seeing them for, what you did, what your assessment was, briefly maybe, what they were here for. Were they here for a well exam? Did they here for a blood pressure check for their meds or whatever? That goes in that one column. So you're keeping track of everybody that you're seeing on that. But there are only certain ones that you get to select which ones you turn in, right?
So in that day, if I see 25 patients, I'll put it on my log.
Right.
And then to actually
When you turn in like your,
this format in APA, then I can just select maybe 10 of them or 6
however many that's due at that time.
required according to.
Right, right, exactly. Yeah, like you're not going to have to do that major, big, long thing we just went over, that review of systems and that head to toe, all of that. You only maybe have to turn in maybe 4 or 5 of those a year. Yeah. Yeah, so you don't have to do that on every single person.
It'll say on there when you have to do it now.
Yeah. Like you might pick 2 of those people that you need to turn in to do that big assessment on, but you might also have a couple regional assessments need to be done, and you might pick a couple of those people that maybe there's someone who came in with abdominal pain. So you want to do your regional assessment on the abdomen and turn that in on that patient. It'll be much more clear when you actually log into Blackboard and you look at the course as a whole. What exactly is due. Read over the syllabus, because the syllabus is going to tell you how many of each one of those things that you have to do and when your due dates are. Any other questions?
Is there a starting date for our,
Very good question. For all clinical courses, there's no clinical done during the first week of class, because we need to make sure that your clinical instructors have those pieces of paper and know where you are. So during the first week, like next week, there will be no clinical. Then you can start the following week. Hit the ground running. How about her?
Can you do clinical in the last week then?
Yeah. I mean, well, usually they'll be getting on you to get your stuff in and get your hours done. And, you know, because your clinical instructors are obviously watching, you know, when things are coming in, when your last log is due. You're going to want to get your clinical done before your last log is due.
Because the 168 is the one that scares me.
Yes, yes, as well it should.
I'm trying to block out some vacation time
the-
to make sure I'm in the running.
Yeah, that's good. Yes.
You know, I came in a few minutes late. Are we turning in today, a paper saying where our clinical is for this semester?
No,
Okay.
no, not today. Soon.
Okay.
And it's not as pressing in 531 because you only have 56 hours as it is in the other 4 clinical courses, because you need to get started with those when you're registered for those. Anybody double registered for 531 and 565? A few of you. Okay, so 3 or 4 of you. Okay. Those ones you're going to want to get in soon, the 565 ones, because you'll be needing to start soon. It's the 531 that you have a little more leeway with because you only have 56 hours to get in. And that's like a third, yes.
For the 565, I'm having trouble finding a pediatrician. Quite a few. Some are not interested, just don't call me back. But we do have a local doctor's office that sees for newborn.
The best thing that I would suggest, if you have a local doctor's office and you think that they would be willing to be your preceptor, is go in, you know, present yourself, and, you know, if you have a minute to talk to the office manager and say, I would really like to do my time here, but I really need to focus on pediatrics. I need 168 clinical hours, the majority of them seeing pediatric patients. Do you think I can get that in? And if they say, oh, we don't see that many, then, you know, you might want to just do a few hours there and keep looking. Keep looking. You know, you don't have to have, things change as the semester goes. You might have an opportunity present itself, you know, and that's when you're going to call up Carol and say, I have a new contract, is that okay? And you're going to talk to your clinical instructor and say, I just found out. We had students that did their women's health last semester who finished up theirs like in October. So there were students who needed hours. So this preceptor actually took a second, you know, student or two from October through the first week or 2 of November to finish up their hours. So things change, and, you know, we're okay with that as long as you keep in good communication with your clinical instructor and we make sure that Carol has the contracts and the documents that she needs. Yes? Okay.
One question, when you said we could come to the campus, now, does that still apply? Because I have a remote problem.
Yes. Well, you know, that is a very good question. I will have to get back to you with that, because that would be, I don't know if they could see you do a physical assessment. I don't know how that would work based on your computer, and Jason would probably be able to tell us that right off the bat. My guess is probably going to be that you're probably going to have to come to campus, but we could ask Jason and he could let us know if that's something that could be done. In the very worst case scenarios, when people have lived very far away, and you'll have to talk to Karen about this because she's going to be your clinical instructor, but in the past, we have allowed students who live 5 hours away to videotape their physical assessment and send it to us. We don't like that, but, you know, we're not mean. We really are not mean people. Yes, your other question.
My other question was 565. I would have registered for that, but when I had inquired about it, I was told that I had to have 531 first.
531 can be taken with 565. Ideally, 531 should be taken all of the P classes, the pathophysiology, pharmacology, and your physical assessment class should all be done before the 4 core clinical courses. But we have allowed students to do 565 and 531 at the same time because they're offered in the same semester. So.
By next week, if I happen to find someone, I can help to register. I don't know if I will because I need some help.
So you have 168 hours and 56 hours. Can you get it all in and get it all done and make an A? Convince me.
That would be the plan. I don't even know if I can find a location.
And Carol would be the one to let you know if there's room. I don't know that there's room, but she,
65 there is.
okay. There you go.
See how much work I get done.
Okay. Yes.
I'm also 5 hours away, so with Charleston, could I do the check off in Charleston?
I think they did do that. Did Lori do that?
She did 531 last.
Yeah. Oh, but she's not doing 531 this
No,
semester.
she was on parole.
Huh. Well, that's another question for me to ask, isn't it? Yeah,
I put my post over there.
yeah, we'll see. Yeah, we'll see.
As long as I can see it.
Yeah. And we don't want any naked partners, you know. You know. That's the thing with the remote proctor is, and that looks like we're going to be meeting on that, and that might be something that is going to be coming down the pike for everyone. We're going to be evaluating the experience that the students that took the final already on remote proctor had. So we'll see how that, we'll be in touch. That's one of those changes that are out there. So,
Talk about the final.
what final? Your final?
531D.
Do you want me to?
Well, because it's on campus.
Yeah.
It's a 5-hour trip.
Yes.
So that's
But
why.
not for us that
She
have.
has
Remote proctor, no. We're actually looking into it because for everyone and for especially for you guys, it may not be mandatory for you guys because you're starting now. It may be mandatory for our students starting in August because it does cut down on trips to campus, but it allows us to have better control over our quizzes. And because we would be requiring you to use the remote proctor for taking all of your quizzes and midterms and final exams. So that would cut down on trips to campus, but it gives us better control, that we feel better that our product is secure. So we'll see how it goes. I know Jason put up. Did you guys answer the
I had,
survey? Did you have a lot of trouble?
I had the most, if there's anything that can go wrong, they'll let.
That's what Jason said. He said there was one student who had trouble, but he said,
That went off like 5 minutes before the test opened.
he also said something about that the glitches that you had should be all worked out now for the future, though.
I hope to God,
Okay.
because I was praying when the internet went out. I was like,
Yeah.
don't do this to me now. You are not taking my A away from me.
Okay.
And it came back.
Very good. So, like I said, there are things that are coming down the pike and changes that are, going to happen, but for the most part, things are rolling along very well, and students seem to be happy and doing well. And please stay in contact with your teachers, your instructors. They are genuinely nice, caring people that only want the best education for you, and it's our responsibility to graduate a good product that's safe. That's our biggest concern, is that we send you out to take care of people and that you're safe in what you're doing and you're writing safe prescriptions, and that you're good at what you do and that you love what you do. That's our goal. So I'm the director. If you have any issues, problems, hopefully not, but any concerns, make sure you let me know. Anything else? Yes.
Another question about the 131 assessment plan. I have my preceptor lined up, but she's had a family illness.
Okay.
So just in case she isn't able to do it, I have someone else who's willing to do it. She works in a pre-admission testing area where she does all of the HEPs and physicals for surgery patients. Would that be something that could?
She says yes.
That's a big thing now. A lot of nurses.
Yes.
Nurse practitioners
Are hired to do this. Does she get to see kids too?
Is it at Wheeling?
Yeah, it's a tough.
Okay, I was gonna say, in our pre-op, our NP and our PA see many children
Yeah.
because they have a lot of ears
Yeah.
and a lot of TNAs.
Yeah.
So they see tons of children.
So that would be my only thing, is to just if they don't see kids, just to make sure you get some, even at this level, because I think there's one assessment that you have to do that's of a younger smaller body part person. I think so. It's across the lifespan in 531.
And then, as far as our name tag,
Yes.
do you want just our name on it?
It's very specific. It comes from the bookstore, and it's very specific, identifying you as an NP student at Wheeling Jesuit University. I'm not even sure. It may even have a picture on it. I'm not actually sure. No, do you have yours already? I ordered it. Okay. Okay. And did you do it at the bookstore today? Okay, perfect. Doesn't have your picture on it.
I was just gonna suggest that they might wanna visit the bookstore today and order
Yeah.
their name tag,
Yeah.
if they have time.
That's up to you. I mean, you should have your credentials on it, at least RN. You know, you should at least have. Yeah. I mean, you should have your credentials on it.
And then as far as wearing like a jacket or what type of
That's a very good question as well. What you should wear into the clinical is what you would wear to work. You should wear dress clothes. You should not go in jeans, or jeggings or tight clothes or things that could be offensive to anybody. You know what I mean, right? But you should wear professional attire with a white lab coat. And it could be the long ones, it could be the short ones. There's no real say as to whichever ones you're comfortable with. And then you may have to change. You may have to put on scrubs, and if they allow you to, once you go there, if they allow you to wear scrubs, that's their decision or whatever. The other thing that has come to mind too is there are certain facilities that are sending us letters about certain things that are required if you do clinical in their hospital, such as I think Fairmont General has something, and CAMC has something about flu shots. Like certain agencies require certain things that we may not as an institution require you to have, but they do as a student. I think there's a smoking thing with Fairmont. And I think CAMC, if you're doing clinical from October to a certain time, you need to have a flu shot. So make sure if you're doing clinical in those areas that you check that site if there's any extra health requirements that are needed before you go there. We try to keep track of that, but sometimes that's impossible with as many students as we have and all the different requirements and stuff. Anything else? Yes? The bookstore. If you go out the main door and just go to your left and walk down the walkway. You'll walk in front of Wayland Hall, is that right? And then there's okay. Right past Wayland Hall is another building where the library is. If you go in there and keep going to the left, you'll run right into the bookstore. Yeah. They're very nice in the bookstore. You may not have a good experience sometimes with the online stuff, but in person I've had some issues sometimes with online things, but for the most part, they are very nice people to help you get your stuff set up and whatever you need.
Did you say anything about the books?
Nope.
Did you get any communication about the books? Remember you said?
Kind of.
Okay. Well, on the syllabus, it's going to say Swartz 2010. It's going to say Ferry 2012, but Ferry's not the main book for this course, either course. So if you don't have get a 2012 Ferry, don't worry about it, because the one I have is 2010. I'm not going to get it. They have 2013. Oh, well, somebody asked me that today on an email. I didn't know.
Very
required for one of the other classes I took. I think they
Yeah.
said class 16.
Right, it is a required, but I mean,
So I
it's
thought
not
it
one of the most required ones for this one. If you did it in 2013, that's 512.
Ferries is a nice reference book, but you don't have to buy one every year.
But
No.
10's okay. That's what I have. I mean, I'm not gonna go get another one just because most of the stuff is in Swartz, all the stuff.
Yeah.
Is that the dark blue one? I don't know what it is. It's real heavy. I can't even-
There's a new edition of the pediatric book as well. I picked mine up today, so guess what I'll be doing this weekend? Updating your course. Yes.
I'm just looking at the clinical experience documentation form that has all the different,
Uh-huh.
So just MSM 531, is there, we need to see X amount of pediatric patients, X amount of...
There's not X amounts of certain patients that you have to see. There's not exact numbers, but there are certain assignments that are related to those age group of people that you have to turn in.
Just we'll know those assignments.
Right, right. Once you start, you'll know those assignments, right? Yes.
So for 531, you're suggesting us not do ER?
Right. Right. You need to be somewhere there's primary care. That's the best thing. Whenever you're asking yourself those questions, well, I wonder if this would be a good place, you can always ask your instructor. I've answered a ton of emails. Can I do this? Can I do that? But always think in your mind, am I going to get primary care experience? And that will usually answer your question.
Because one semester we had a patient, or a student that wanted to do all of her clinic with a hospitalist for primary care. Hospitalist is in a hospital. I mean, he may have an office and do primary care, but this was in the hospital, and that's not primary care. That's secondary care. We
Yeah.
couldn't allow her to do her clinical with the hospital. Unless he was in the primary care office, which kind of.
Could you split it up and do it with two? Because in my situation, I have one girl that's gonna do family care, but she is on maternity leave and she's not coming back till March.
Mm-hmm.
So I was wondering if I could do the ER some of it, and then when she comes back in March, finish with her.
Is that 4560?
Well, in 531.
531.
I know, but I don't mean,
I mean, that's 2 months, I mean.
Yeah.
Less than 2 months, but.
could I start and wait until March? Do clinical time?
Oh, I've had that happen.
Stuff you have to hand in.
Yeah.
Sit down and remember the exact dates, it's like every month you have, or every week you have to hand in something on some body part.
The earlier you can start is better. You know, I would definitely try to start somewhere, but I don't know that the ER is a great place for you to be, if that answers your question.
They don't check it, I mean, they don't always do it ahead.
Right. Chief complaint, HBI, regional assessment, whatever test you're done. You know what I mean? So you won't get answers to a lot of the questions that you're gonna need to be filling out your forms and stuff correctly for an ER. Okay?
Well, I'm just discouraged now because they said okay and I got everything all set up.
ERs are not the best. I mean, ERs are great for certain things, but they're not the best for where you're at right now in a program. You know, and we've had students that are working ER, you know, and they want to do, you know, stuff like in ICU, or because they have different goals and they're just doing their F&P to actually get to be, when what they really want to be is an acute care NP and not an FNP. And you know, sometimes you have to, what our goal is and you're graduating from this program may be different from what your ultimate goal is. And as much as we can mesh that, we will, but we have definite requirements that you have to meet the graduation requirements, so to be able to take your test. You know, a lot of our stuff, our hands are tied as well. You can't do any less than the clinical hours that you're supposed to do. You have X amount of clinical hours, you have X amount of pharmacology hours, you know, in order for me to be able to sign that, yes, you graduated from this program and can take your test. Anything else? Yeah.
Do you recommend, like, is there a certain type of etiquette in approaching people that maybe you don't know? Should you send a letter? Should you send an email?
You mean when you're trying to request a
Yeah, like you
clinical
say, you
site?
know, hey, I'm so-and-so, and I'm a student here, and I would like to do, you know, clinical hours, or do you just walk in and be like, oh, hi, I was just wondering if y'all take students? I mean,
I have a lot of times students will try to get in with, like, network with people that they work with, or, you know, maybe they're working in a hospital and whoever you know, maybe there's a physician that, you know, is a family practice or something that they know or somebody else knows, or A lot of times it's networking kinds of stuff. And whether you do the phone call or, whatever you feel is better, there's not a protocol for it. If you're walking in cold, sometimes a phone call is not, it's 6 of one, half a dozen of another. You could very well get, office manager on the phone and get her at the right time and be perfectly fine, whereas you show up in person and it's on a busy day and they don't want to see you at all. It's like being a pharmaceutical rep. I don't have time for you today. That kind of stuff. And it's not meant to be mean, it's just the nature of healthcare and the time that is spent.
And one other question, talking, I know you said you hesitated to mention it, but I do have a question about the possibility of offering 566 in the summer. Is that something that you anticipate that may happen this summer, And would it be, I know the summer sessions are divided up into summer, like.
This will be all summer long, probably from the,
May to August,
yeah.
okay. And
Yeah.
when will you know for sure?
When will I know for
When do
sure?
you think you might know for sure?
Well, before the summer.
Say they will teach the class.
We do have faculty that have volunteered to teach the class, so we,
Many students interested in
so,
teaching with them for the summer.
yeah, we'll have to see how that goes. But it was actually one of our adjuncts who mentioned it, that might be something for us to think about, and, we try to listen to what people suggest. I actually thought it was a good suggestion, and our faculty have been supportive of that, so we're hoping that, but we'll see. Yeah. We like to have a little vacay every now and then too, and yeah, we'll see. Yeah.
I will mention, I talked to my children's pediatrician about the pediatric rotation, and she said it depends on the time of the year, because as you mentioned,
Right.
it's so much busier in the fall.
Right.
They don't take students in the fall.
Right. Which is when they really should take students.
But she said it's so busy that they don't have
Right.
time to finish.
That's exactly right. That is exactly right. And that's their choice. Yeah. Sorry, I didn't turn my phone on silent. That's my daughter. I'll have to get back to her. All right. Okay, any other questions? Thoughts? Did we pretty much cover everything? All right, I appreciate those of you who drove far to be here, and I hope that it was worth your while. I hope you got a lot of useful information. If you want to go to the bookstore, Carol's going to parade you over there. And have a great semester. Let me know if you have any problems. Sure.